Welcome everyone to this USMLE Step 2 Clinical Knowledge Walkthrough on Heart Failure. I'm excited to share some high-yield test-taking strategies that will help you master board-style questions. Today we'll work through several practice questions together, breaking down exactly how to approach them on test day. Let's get started with our roadmap to residency success.
Here are our learning objectives for today. By the end of this session, you'll be able to distinguish between systolic and diastolic heart failure using clinical and diagnostic clues. You'll apply acute decompensated heart failure management principles to question stems. You'll identify which medications reduce mortality versus which only improve symptoms. And finally, you'll master diuretic management strategies that appear frequently on boards. Let's dive in.
Before tackling questions, you need a solid framework. Ask yourself 2 questions with every heart failure case. First, is this systolic or diastolic? Systolic means reduced ejection fraction, 40% or less. The heart can't pump. Diastolic means preserved ejection fraction, greater than 50%. The heart can't relax and fill. Second, is this acute or chronic? Acute requires urgent intervention. Chronic focuses on medication optimization. This framework will guide your answer choices. Here are the medication pearls that show up repeatedly on board exams. For acute decompensated heart failure, think diuretics first for volume overload. The classic mnemonic is still useful. For chronic heart failure with reduced ejection fraction, you must know the 4 pillars. These are the medications proven to reduce mortality. Board questions love to ask which medication to add next, or which medication provides mortality benefit versus symptom relief only. Remember, furosemide and digoxin improve symptoms but do not reduce mortality. Let's work through our first question. Read this stem carefully. Notice the patient woke from sleep with shortness of breath. He's using 3 pillows. He has elevated JVP, bilateral crackles, and peripheral edema. Oxygen saturation is low. What pattern do you recognize? What's the first-line treatment for this presentation? Take a moment to think before we go through the answer. Let's break this down systematically. The paroxysmal nocturnal dyspnea, the orthopnea with 3 pillows, the elevated JVP, crackles, and edema all point to acute decompensated heart failure with volume overload. The correct answer is intravenous furosemide. Loop diuretics are first line for pulmonary congestion. Don't pick beta blockers in acute decompensation. Don't pick digoxin or ACE inhibitors as first line for acute presentations. These are chronic management drugs. Here's our second question, focusing on the systolic versus diastolic distinction. Notice the ejection fraction of 60%. That immediately tells you this is preserved ejection fraction, meaning diastolic heart failure. The left ventricular hypertrophy and impaired relaxation confirm diastolic dysfunction. This patient is an elderly woman with hypertension and diabetes, which are classic risk factors. The question is asking what medication to add. Think about which medications have evidence for heart failure with preserved ejection fraction. This question tests whether you know that treatment differs between systolic and diastolic heart failure. For years, we had no mortality-reducing medications for heart failure with preserved ejection fraction. Now, sodium glucose cotransporter 2 inhibitors have changed that. Empagliflozin and dapagliflozin have shown benefit. The test-taking strategy here is to always check the ejection fraction. If it's preserved, the standard 4 pillars for reduced ejection fraction may not all apply. Look for the newer agents that have evidence across both types. Now let's tackle chronic medication optimization. This patient has systolic heart failure with ejection fraction of 30%. He's already on lisinopril and carvedilol. The question tells you his blood pressure and labs are acceptable. What's missing from his regimen? Think about the 4 pillars. Which ones does he have and which does he need? The question is specifically asking about mortality reduction. Let's work through the medication optimization systematically. The patient has pillar 1 covered with lisinopril. He has pillar 2 covered with carvedilol. He's missing pillar 3, the mineralocorticoid receptor antagonist, and pillar 4, the sodium glucose cotransporter 2 inhibitor. The question confirms his potassium and creatinine are acceptable, meaning it's safe to add spironolactone. If the question asks what to add next, Either a mineralocorticoid receptor antagonist or a sodium glucose cotransporter 2 inhibitor would be correct. Note that furosemide is not a pillar because it doesn't reduce mortality. Diuretic resistance is a favorite board topic. This question presents a patient who isn't responding to high-dose intravenous furosemide. He still has edema and minimal urine output. His creatinine is rising, which might make you hesitate. But look at the clinical picture. He's still volume overloaded. The question asks for the next step in diuretic management. Don't be fooled by the rising creatinine into stopping diuretics. This question tests your understanding of cardiorenal syndrome and diuretic resistance. When loop diuretics aren't working, the classic next step is sequential nephron blockade. Add a thiazide-type diuretic like metolazone, which blocks sodium reabsorption at a different site. This overcomes the compensatory increase in distal tubule reabsorption. The key insight is that in heart failure, rising creatinine is often from venous congestion, not from the diuretics themselves. Achieving euvolemia can actually improve kidney function. Don't let the creatinine scare you away from adequate diuresis. This multiple-choice question directly tests mortality benefit. The question explicitly asks which medication helps the patient live longer. This is a common board question format. Before looking at the options, recall which heart failure medications reduce mortality versus which only improve symptoms. Each answer choice represents a different category. Take a moment to think through each one. Let's analyze each answer choice. Digoxin reduces hospitalizations but has never been shown to reduce mortality. Amlodipine is safe in heart failure but provides no mortality benefit. Carvedilol is one of the 3 evidence-based beta blockers that reduce mortality. Hydralazine alone does not reduce mortality. It must be combined with nitrates. Furosemide is symptom relief only. The correct answer is carvedilol. Always remember the 3 beta blockers with mortality data: metoprolol succinate, carvedilol, and bisoprolol. Not all beta blockers are equivalent in heart failure. Thanks for watching this heart failure question walkthrough. Remember to review these concepts in your first aid and board review resources. Practice additional questions in your question bank, filtering specifically for heart failure topics. The more patterns you recognize, the faster you'll be able to answer these questions on test day. If you found this helpful, please like and subscribe for more high-yield board content. And if you want personalized tutoring or residency advising, visit roadmaptoresidency.com to connect with our expert team. Good luck with your studying.